Alrighty, so thank you everyone for coming today to Grand Rounds. My name is Samir. I'm subbing in for Dr. Azam today. So today we have a topic that is very interesting to me as I see MINOCA fairly often on the ward. So very excited to hear Dr. Jose Winter speak to us about this. For those of you who haven't met him, Dr. Winter is a general cardiologist here in Hamilton. He completed his medical training in Chile and has been with McMaster and Hamilton Sciences the last couple of years and has recently taken on the role of medical director of comprehensive cardiology clinics in the stress lab. So thank you so much, Dr. Winter, for coming to speak with us today, and I look forward to hearing what you have to say. If you have questions, feel free to put it in the chat or raise your hand during or after the presentation, and I'll be monitoring that and letting Dr. Winter know. All right, Dr. Winter, so I'll hand it over to you.
Thank you very much. I'm very thankful for this invitation. Let's start with a land statement. We are privileged to provide care on lands that indigenous peoples have called home for thousands of years. We recognize and respect the presence of and stewardship of all indigenous peoples as keepers of this land. So we're going to talk today about the topic of MINOCA, that means myocardial infarction without obstructive coronary disease. This is a topic that I was telling Samir that I've been a cardiologist for almost 15 years now, and this is a topic that has changed so much since we were training. When we were training, people were admitted with this, and we would send them home telling them that they had mostly nothing, and they could continue with their lives. And now we have learned that a lot of things are happening, and now we have more ability to diagnose what's going on. So MINOCA is not that infrequent. Of all the admissions for MI, they account for around 6 to 15%. So it's a very prevalent situation. And we have to always understand that MINOCA is only a working diagnosis. So a patient hopefully shouldn't go home with a diagnosis of MINOCA. They should have an etiology of at least that etiology is found, or at least a plan to understand what's going on. But it does encompass several different causes. And with an advanced approach that we have now, we can find the etiology in most cases. And also, because there are so many cases, different situations, and the etiologies are different, we should try to tailor the therapies for each situation. So it's been some years now where the cardiology elders spoke to us, and they gave us this amazing paper called the Fourth Universal Definition of Myocardial Infarction. And I always like to remind, especially when I work in patients with our residents, that there are different terms that we have to understand before diagnosing a patient. And one of them is the concept of myocardial injury. The myocardial injury is defined as a troponin elevation with at least one value about 99% percentile. And it has to be acute, meaning it has to have a rise and fall. Okay? If it's persistent, it's called a chronic injury. And then an MI is defined as injury plus ischemia, meaning symptoms of myocardial ischemia, new ischemic ECG changes, development of pathological Q waves, imaging evidence of new loss of viable myocardium or new wall motion abnormalities, or in an angiogram, or hopefully not an autopsy, you should see thrombus in the coronaries. So what is MINOCA then? So MINOCA is a myocardial injury with signs of ischemia, so a myocardial infarction, but then you have to have no obstructive coronary disease, meaning less than 50% stenosis in an epicardial artery or overlooked form of obstructive disease, and no clinically overt specific cause for this acute presentation, meaning myocarditis, Takotsubo, etc. Okay? So again, MINOCA includes a group of atherosclerotic and non-atherosclerotic situations. And the incidence of MINOCA has increased progressively, mostly because we have better tests now, and that is the high-sensitive troponins that they can detect very small degrees of damage to the heart muscle. And when you say that a patient has a MINOCA, you have to rule out non-ischemic causes, meaning especially Takotsubo and myocarditis. And also the spontaneous coronary dissection with a more than 50% stenosis is not considered a MINOCA. So, but it can be a MINOCA if we missed a dissection, and we understand that later. Okay, so if a patient has a coronary dissection with a less than 50% stenosis that we are not sure that it's a coronary dissection, it can also be in a MINOCA. And also we have to rule out all types of type 2 myocardial infarction. So we always have to check for supply-demand mismatch, tachyarrhythmia, sepsis, anemia, hypotension, etc. So in 2018, there was this interesting group of patients that was published. It's called the Virgo study, and that took in account of a lot of admissions in patients that had to be between 18 and 55 years old that were admitted for MI. And they separated them between patients who had a MI that was related to coronary disease and MINOCAs. You can see that they accounted for 11% of the admissions. And you can see that patients with MINOCA are slightly younger. They have a higher tendency to be women, almost 90% in this trial. And also they had less risk factors, such as hypertension, diabetes, dyslipidemia, smoking, obesity, family history of CAD, or any of the risk factors, or previous MIs. So the population that has MINOCA is different from the people with normal heart attacks. And also you can see that people with MINOCA have a higher tendency to have a non-STEMI compared to a STEMI. It's almost 80% compared to 50% in the other group. The length of hospital stay was the same. And also it's interesting that the peak of troponin was a little lower, but the degree of significant LV dysfunction was similar in both groups. Still, the number is very low, so it's 10% almost versus 11%. But so a MINOCA can also cause LV dysfunction. It can be a significant MI. It doesn't mean it's not a significant MI. And in this group, they assessed the mortality at 12 months, and you can see that the mortality in MINOCA is slightly lower than MI, but it's higher than a normal person. But also interestingly, the quality of life, the persistence of angina, or the dissatisfaction with the treatment we provided are almost the same. So a patient with a MINOCA will behave very similarly to a patient with an MI, but the mortality will be slightly different. And this is a big meta-analysis published in 2015. And you can see that patients with MINOCA have an in-hospital death around 1% compared to 3% in MI, and at 12%, 3.5%, and 6% compared to 6.7%. So we do know that patients with MINOCA don't have a benign prognosis. This is a not benign situation. And in this trial also, it's very interesting that you can see that most of the patients, so of all MINOCA, most of them were sent home with a diagnosis called MINOCA undefined. So no etiology was found. And in these patients, the treatment was aspirin, statins, but with 80% or so of prescription of those medications, sometimes beta blocker, but the therapy was very different to the patients with CAD, but it's also not very clear why they are receiving that medication. So how can we provide a better care or a more accurate diagnosis for the patients with MINOCA? And that has changed in the last couple of years. So how do we navigate through MINOCA? First, of course, we have to make the diagnosis. So a patient has to have an MI with all the criteria, with less than 50% stenosis on CAT, and the usual assessment with an ECG to see the changes, an echocardiogram that can also help us rule out other causes of troponin elevation, like pulmonary embolism or Takotsubo, etc. Okay. Second, we should sit down as cardiologists and review the CAT for missed situations that could diagnose what happened to the patients. Okay. So, for example, this is an angiogram of a patient who had an MI, and it was reported as normal, but then you can see this tiny marginal branch that is occluded there. So maybe that was the cause of this small MI the patient had, and we missed it because we didn't review it carefully. Or for example, this one that has a very small narrowing of the vessel, it looks very insignificant, maybe 20 to 30%, but it ended up being intramural hematoma, so the patient has CAT. So we should review the CAT with like close eyes and be very, or sometimes ask someone else to look at it to see that we're not missing anything. And maybe the diagnosis is there right away. So now, after we review the CAT, we have to try to exclude the mimicking diagnosis. So we're going to focus in the right side of the screen. The most common mimickers of MINOCA are Takotsubo, myocarditis, and type 2 MI. So I'm not going to go too deep in those type of situations, but I'm going to try to discuss mostly how we differentiate one from the other. So Takotsubo is very frequent and usually happens in postmenopausal women. They have classic wall motion abnormalities. Remember that there's a classic Takotsubo in the apex, but you can have a mid-cavity Takotsubo and other less common types of Takotsubo. And also they tend to have, a good proportion of them will have ST elevation, especially in the anterior legs, but you will see a very big wall motion abnormalities, and the troponin elevation won't be as impressive as the wall motion abnormality. That also sometimes help us think about that. And myocarditis on the other side usually happens in young males. They have a viral prodrome, and usually they can have elevated CRP. And the mechanisms for chest pain for those can be associated pericarditis, but also they can have spasm of the coronaries and even thrombosis of the coronaries, okay? And also we have to rule out again the secondary causes like P, atrial fibrillation, sepsis, anemia, etc. Also, a very frequent conversation I have with the residents is that sadly, the peak troponin levels are not that helpful to differentiate a type 1, type 2, or even a myocardial injury. This is a big report of patients with different types of MI, and they show the degree of troponin elevation. And you can see that even people with MI will have a tendency to have higher troponin levels, but they tend to, but the troponin levels tend to be, they overlap, sorry, that's the word. They overlap between the type 1, type 2, and acute myocardial injury. Usually the chronic myocardial injury will have lower degrees, and most patients will be in the 50s, but there's a lot of overlap between the three curves, so it's hard to diagnose what type of MI we're seeing only with the levels of troponin. And even if they did a rock curve, you can see that if a patient has a 5-fold increase of troponin, it will only give you a 75 positive predictive value for type 1 MI. And in patients with chest pain, it will be only 60 to 65%. So the level of troponins will not tell us what kind of MI we're seeing. So I have a couple of cases. It's very interesting because I decided to do this topic like a month ago, but then I saw all these patients during my rounding in the hospital. So it's very interesting that they are frequent and you can have a lot of interesting cases. So this is a 48-year-old patient. He's very active. He works in a strenuous job. He's completely healthy from before, but in the last week, he noted chest tightness while running on a treadmill. And later the day he came to the hospital, he had crushing chest pain that was retrosternal, related to arm and jaw, so classic angina, and became diaphoretic and cold. And there was some intermittent palpitations. So the patient arrived to the hospital. He was hemodynamically stable. His ECG showed no clear signs of ischemia, only a couple of PVCs. And then the echo showed no wall motion abnormalities, and the troponin was 3,000 and downtrending to 2,800. And this is his angiogram. So this is a cranial view. You can see this is the left territory. You can see the LAD going down, a big circumflex that has no signs of, a big circumflex that has no signs of coronary disease. The LV is quite normal. And the RCA also is quite normal. You can see the RCA is very smooth, 0 signs of coronary disease. And this is another case I saw like during the same days. A 63-year-old female, past medical history of basal cell carcinoma, previous COVID in 2022 that left a lot of sequelae, but the lady is feeling mostly fine, but he was under a lot of stress because her son was moving back home and they were having some trouble. And then she started having this sudden onset chest pain that was oppressive. His neighbors came, her blood pressure was very high, 200 over 100, and did not subside with nitroglycerin by EMS. The troponin was 2000, and the ECG was quite normal again. And this is her coronary arteries. There's a wiring because they had trouble engaging in them, but they are very normal. You can see the circumflex artery here. You will see also the RCA here, and this is the LAD that also looks quite normal. But this lady, her LV gram will show a very clear wall motion normality here in the anterolateral, apical, and diaphragmatic segments. That you can also see in the echocardiogram how the bases are contracting with more intensity and all the mid segments and the apex are not moving that well. You can see that again. So this lady was diagnosed with a Takotsubo and all her evolution was concordant to that situation. So how can we improve our diagnosis accuracy? And one of the tests that have appeared to be extremely helpful in patients with MINOCA is MRI. So MRI is not widely available, and sometimes the waiting is long, but hopefully it should be performed in all patients with MINOCA because its most important role is in ruling out non-ischemic causes, okay? But even if there's an ischemic cause, it will provide accurate vascular dissolution and extension of the MI. So it can be really helpful to diagnose if this is an ischemic or non-ischemic cause. And the MRI, I'm not an MRI expert, but the MRI has this incredible ability to do tissue characterization using these sequences T1 that can help us understand what type of tissue and detect inflammation, and T2 that detects mostly water, that's edema. And then the late gadolinium, that is a contrast that will detect sites of fibrosis, okay? And the pattern and distribution are very helpful to understand what is the cause of the situation. As I told you, sometimes it's not easily available, but still will be helpful, okay? So the cool thing about the late gadolinium enhancement is that it will stain the parts that have fibrosis. And if patient has an ischemic cardiomyopathy, you are going to see a pattern that will be or transmural or it will be subendocardic. But the late gadolinium enhancement will start in the subendocardium because of the coronary distribution. But if you see a subepicardial enhancement, that speaks about a non-ischemic cause because it makes no sense in a circulation point of view. Also in an intramyocardial or a patchy where you can see this foci everywhere. So if we use these advanced techniques that can help characterize, so the high intensity will show, and in this case, the high intensity is in the yellow. You can see this yellow patching everywhere. And then with this tissue characterization technique, you can see it everywhere with late gadolinium enhancement that is in the epicardium. So this is suggestive of myocarditis. And then at Takotsubo, you're going to see this inflammation in the mid segments, but without necrosis with the late gadolinium enhancement. So that is suggestive of Takotsubo. And when you see an MI, you will see transmural damage, like here. They're going to see in brown, everything in brown is necrotic, and actually there's a part in blue because that part, there's microcirculation obstruction, so the contrast is not able to get there. But you're going to see this transmural or subendocardial damage that you can diagnose. So it will help us understand what caused this, or will help us understand if there's a non-ischemic or ischemic cause of MINOCA. And actually there's a experience in 2024 that shows 888 patients who had a MINOCA and then went CMR during their admission or initial discharge period. And you can see how the MRI was able to reclassify 78% of the patients into MINOCA or non-MINOCA, including myocarditis, Takotsubo, especially hypertrophic cardiomyopathy, or normal, okay? And you can see how a lot of patients change their diagnosis during this MRI experience. And you can see how many, like half of them were uncertain, and it was able to clearly identify infarcts, myocarditis, etc. One of the things, because the MRI is not that easy to get, if you have a patient with a clear Takotsubo wall motion abnormalities on echo and normal coronaries, the echo will give you a 95% specificity for Takotsubo. That means that maybe MRI is not needed, especially if it's an elder lady. For example, the pretest probability is so high that maybe we can save the MRI for other patients, especially for young patients. But it's very important to understand that all these findings, especially the edema, will go away after some time. So the closer you do the MRI to the event, the better accuracy we'll have. You can see, like, if a patient has a myocardial infarction in the first 2 to 4 days, you will have a 23% findings of FMI that will continue in the end because necrosis will be seen and it will have a vascular pattern. But for example, Takotsubo, that is mainly inflammation, you will have a 35%, and then it will go to 0% at 6 months because it should have been resolved. Myocarditis is the same. Not all myocarditis will leave final fibrosis, so the threshold will decrease. And if you do it later, you will have a higher percentage of normal patients. And this is, again, the same. You can see this is several different trials and show that if you do it at 30 days, the percentage of normals will increase to 25% compared to 0% if you do it in the first 3 days or so. Okay, so the closer to the event you do the MRI, the better, or at least we can try to plan an MRI in the as close as an outpatient as possible, because you will still have some information that can be helpful. So coming back to case number 1, the young patient with chest pain and troponin elevation with normal coronaries, they did an MRI. It was very fortunate that the MRI was able to be done right away. And you can see this high intensity defect in the basal septum, in the anterior basal septum. And you can see this is suggestive of myocarditis. What is very important for these patients is now that we know that has myocarditis, we will adjust the medication. And also myocarditis, the recommendation, he's a very active patient, and the recommendation after myocarditis is 6 months of non-high intensity, so of no high intensity exercise, okay? So for this patient, he will require long leave from his work compared to patients with an MI that will go home and after a month or so, they will be ready to restart their physical activity. So now we're going to go to the non-atherosclerotic, we're going to go to the atherosclerotic causes. That they account for 2/3 of MINOCA. So still, most MINOCAs will be related to atherosclerotic causes. So this is another case. It's a 68-year-old female. She has a history of asthma, ischemic colitis, celiac disease, and she smokes marijuana daily. And she had an episode of long-standing angina. The ECG showed no clear signs of ischemia, and the echo did not show wall motion abnormalities. And the troponin was significantly high. And you can see, this is the ECG that had only a PAC there, no signs of ischemia. And this is her, these are her coronaries that you can see. This is a non-dominant RCA that is quite normal. But then in the LAD, I will start it, but I want you to take a look at this segment, that is the LAD, that has a small, very small narrowing there, maybe 30%, no more than that. But you can see how it becomes thinner and then it recovers the diameter. And the LV function was described as normal. Maybe there's a little bit of hypokinesis here, but it was normal. And she was sent, and so in this case, we have a lady who has some coronary disease risk factors and has only a 30% stenosis in the LAD, but with an episode that sounds very ischemic. So what are the atherosclerotic causes? So the most common one still is plaque rupture. That accounts for 75% of all acute coronary syndrome. And that happens usually in a thin fibrous cap of the coronary, of the atherosclerotic plaque that will breach, and all the of necrotic lipid core will be exposed to the bloodstream. That usually produces a high thrombus burden. Usually it's red thrombus that is full of fibrin, and usually produces impaired flow. But if the process is not completely occlusive, you can have an end stem instead of a STEMI. Plaque erosion is a diagnosis that is going up because we have better ways to diagnose it. But right now it accounts around 20% of all acute coronary syndromes, but it could be underestimated. And usually it happens when a more stable plaque only gets a superficial erosion of the endothelium, and there's a smaller degree of thrombotic response, usually with white thrombus. That means mostly platelet rich. And these small amounts of it can embolize distally. And usually it happens in patients with lower CAD burden and also in patients with more stable plaque. And maybe that is changing because we are acting before in patients with dyslipidemia or NONs or CAD detected with different methods. So we're giving them more better treatments with statins and other drugs with pleiotropic effects. So we're causing this more with stronger, more resilient plaques. So when you have the concept is that you have a small erosion and then there's a white thrombus that usually is non-occlusive, but small fragments of it can embolize distally, compared to this one where the plaque rupture, where all the lipid core will be exposed to the circulation, and then a big red thrombus will come and most of the times will occlude the vessel, okay? And then there are risk factors that make plaque rupture more probable, like hypertension, like all coronary disease risk factors, including multivessel disease, and usually happen during the winter. And in the plaque rupture, you can see it's more frequent in women, younger, people who smoke, usually presents as an end-STEMI, and usually happens in the LAD territory near bifurcations. And can happen mostly during, well, it does not happen more commonly during the winter. Another very interesting situation that can happen locally and produce a MINOCA, it's a calcium nodule. This is also a new type of diagnosis. It happens when these coral-like calcium nodules that are inside of the plaque, they rupture they protrude and they protrude and they rupture the intima. So these calcium spikes are exposed to the circulation, and they can also get thrombosis because of, and then embolization distally producing acute coronary syndromes. The treatment of these ones is more challenging because fixing this with stents is harder. So you have to usually use advanced tools to reduce this calcium burden, especially rotablation that is similar to a small tool that the dentist use to open the teeth, but it can be very helpful to open the vessel and then put a stent in. So we are going to try to attempt to identify the etiology of patients with MINOCA using more advanced techniques. And a revolution has happened to us after we were able to obtain intravascular imaging. Our favorite one is OCT. OCT is a technique that uses infrared imaging and is able to give us a very clear histologic diagnosis of the vessel. So you can see actually here the intima, the media, and the adventitia of the vessel with great resolution, and it can show small abnormalities in the vessel that before we're not able to see. We can also use IVUS, that is an ultrasound machine, but usually OCT is the one we use more. And for example, if you see a plaque erosion, you're going to see very clearly that there's a plaque here. And then there's this thrombus that is white thrombus. We can differentiate white thrombus from red thrombus because white thrombus produces less shadow distally, and you can see a very clear thrombus that is adhered to this vessel and is non-occlusive. So this is most probably a plaque erosion compared to this one that is a plaque rupture that you can see red thrombus with a lot of shadow distally, and you can actually see the hole that the rupture of the plaque where now it emptied all the lipid that was inside. Now you can see a hole there, also a cavity. And for example, this is a calcium nodule that you can see a very clear well-defined abnormality here that is calcium that is protruding into the artery. And again, we can differentiate red thrombus according to how it looks, like it looks heterogeneous and with a lot of shadow compared to white thrombus that is more clearly seen and with less shadow. But also this is very helpful too when you see a normal coronary artery, especially in patients with a Takotsubo or an embolization or a thrombus that does not come from the coronary arteries. If you see a normal coronary, you know that most probably nothing happened locally there and it's coming from outside. Or if it's a Takotsubo, the biggest differential diagnosis with a Takotsubo because of the wall motion abnormalities is an LAD infarct. So if you see a normal coronary artery, then you know that there's a huge chance that this is a Takotsubo. Back to our case, the lady with chest pain and troponin elevation with this 30% stenosis of the LAD had a plaque erosion that was clearly seen here with white thrombus with less backscattering, and she was treated medically with aspirin, clopidogrel, beta blockers, etc. So we're going to talk a little bit about the non-atherosclerotic causes of this. So SCAD, as you know, is a disease that is more frequent in women, and the blood flow is obstructed mostly because of the development of this intramural hematoma that can occlude the vessel, and then there's an intimal tear that sometimes causes decompression. Okay, the diagnosis is most of the times angiographic. So most of the times you will see it in the angiogram and have a clear idea of what's going on, but still you can miss this diagnosis, especially if you're in this stage. Okay, the use of intracoronary imaging can be really helpful for this. And the predisposition, of course, this is more frequent in patients with muscular dysplasia or vasculopathies such as Ehlers-Danlos or Marfan. Angiographically, it looks like this. This is a classic dissection where you can see actually the flap there or here. But in some cases like this one, that you can see this sudden change in the vessel diameter that looks very clearly as a dissection. They gave him nitroglycerin and it completely improved. So this was a spasm and not a coronary dissection. Or in this case, that this patient had an angiogram that appeared to be normal, but then an MRI showed that there was a necrosis there, and then they did a new angiogram a couple of months later, and you can see that there was a dissection and the vessel was occluded. And now you can see clearly that that is the actual vessel that we could not see before. Okay. Embolism is rare. The coronary arteries, when they embolize, you can see these images that are translucent and usually have at least three points where the contrast goes in. So they have this appearance of where we can diagnose thrombus. We can aspirate them and improve the flow. Not all of them will need stents. And then embolization from another part or from the coronaries is uncommon, less than 3% of all MIs. Usually they can be systemic, but they can happen coronary, and the most common source is problems during the procedure. You can get clots in the catheters and push them in, or small dissections in the origin that can produce a local clot and it can be dislodged distally. But if that is not the case, the most common sources are infective endocarditis, atrial fibrillation, prosthetic valve thrombosis, or iatrogenic, myxomas, etc. Usually the treatment, again, as I told you, is aspiration. You can take them out and restore the flow. And if you do images, most probably you will see a healthy vessel. And the treatment is not clear. Most probably these patients will require at least 3 months of anticoagulation. And then they should be assessed if they need procoagulation studies, thrombophilia studies, or will end up with 3 months of anticoagulation. Very interesting is vasospasm. Vasospasm is a dynamic procedure, so it's very hard to diagnose. Most people will complain of chest pain with ECG changes that usually is ST elevation, that usually they respond very well to nitroglycerin. Usually these patients smoke and they have more symptoms in the morning, but also it can be reactive to some drugs like syncofluoracil, toxins like cocaine that is very frequent, or tumors such as pheochromocytoma. Because it's dynamic, you can go into the coronaries and you're going to see a normal coronary unless you see a clear spasm like the case before, but you're going to see a patient with normal coronaries and it's going to be really hard to diagnose. And then there's this new chapter that is coronary microvascular dysfunction. That is, its prevalence in patients with MINOCA, it's not known, but apparently its incidence is being seen more and more. It's a spectrum of different diseases that they are now also a topic of interest in cardiology. And it can happen because of two things: the inability of the tissue to vasodilate, or the phenomena of spasm producing vasoconstriction that can be also dynamic, and it can happen in the epicardial circulation or the microvascular circulation. So you can have abnormalities in flow that can be structural, that usually are very easy to diagnose in the coronary angiogram. But you can have functional episodes like the spasm that is really hard to diagnose, or you can have microvascular situations that will produce difficulties for the blood vessel to dilate, like capillary rarefaction, that is a thickening of the microcirculation, or intravascular plugging, or fibrosis in patients with LVH, for example. And then you can also have spasm of the microcirculation. So diagnosing this is not that easy, but we have the ability to do it. We have a team that is taking care of these patients, and we can do microcirculation tests. They are called the coronary flow reserve or the intramuscular reserve. And they are based the same as in the Swan guns. They are based on dynamics of flow of fluids and or Doppler imaging to understand the flow. And then you can calculate resistances and see if they change during hyperemia, saying they will show us the ability of the tissue to dilate. But also we can have tests for spasm. You can do an infusion of acetylcholine or ergonovine, and that is a very safe, only procedure, 0.5 major complications, and the diagnosis of spasm will happen if the patient will develop chest pain and ECG changes. And after nitrates, it should improve. So continuing with our case, the lady that we saw before that had a plaque erosion, she was discharged with medical therapy. But on follow-up, she continued having episodes of chest pain that were similar to her MI admission. And a new stress test was negative. So she had imaging again, and you can see that the LAD, you can see how the machine is moving there. In the LAD, she still has that plaque that it looks, to our eyes, it looks that the plaque in this side looks with a thin plaque ateroma, but it's healed. There's no clot right now, and the flow is normal. But then they did these tests of microcirculation that was normal. But then they did an acetylcholine infusion, and you can see she's developed chest pain that was very significant with ST elevation. And you will see that the artery now looks more narrowed, but it's more clear when you see it after nitroglycerin infusion, how the LAD grew significantly. So she was positive for spasm, and she was started on calcium channel blockers with very good response. Other tests can be helpful if a patient does not want to undergo a cardiac catheterization. If they have a MINOCA, you can still do a cardiac CT. That will be very helpful, especially if it shows the absence of significant stenosis. And also the PET can be helpful because PET can provide some measurements of coronary microcirculation that can be helpful in patients with microcirculation abnormalities. So first, we're going back. Now we have identified the etiology. I did put here, you're invited, so please involve us in these cases. They are very interesting, and sometimes we can help understand what's going on and plan the patient's treatment. And there's a new publication that takes in account this kind of approach to patients with MINOCA, with OCT and MRI. And you can see that this paper was published in 2021, and it was very graphic to see if we change our approach to MINOCA patients, we can diagnose most of the etiology that's going on. And you can see that it was 170 patients with MINOCA, and they did 145 OCT images and 116 CMRs. And you can see that patients, they could identify the causes almost 85% of patients using this approach. So using this approach with advanced imaging of the coronary arteries and MRI, we can get to a lot higher identification of the cause of patients. Still, myocardial infarction is the most frequent one. And they show these very beautiful cases. And for example, this is a patient who had normal coronary arteries and they did an OCT, and the OCT has this bumping of the endothelium. And that bumping of the endothelium can happen in people who have spasm. And that was relieved by nitroglycerin. And when they did the MRI, the patient actually had a late gadolinium enhancement in the subepicardial region, suggesting a myocarditis. So the patient was having a myocarditis with coronary spasm that was causing the episodes of chest pain, and all was diagnosed using this approach. Last year, the CCC published these new guidelines on how to approach patients with MINOCA that is very useful. And you can see there's this workflow that shows what should we do in these patients. It has two major parts. One of them is having the MINOCA, then diagnosing with a coronary angiography and evaluate if there's a chance of having a SCAD. If there's any alternative explanation, then it's not a MINOCA, but if there is no alternate explanation, you should again re-review the angiogram to see if we're missing a side branch occlusion or non-obstructive SCAD, then a TTE to rule out Takotsubo. And if there is no Takotsubo, SCAD, or MIS-CAD, we should go to the second part of this with a cardiac MRI, if it's available, hopefully in the next 2 weeks from the event. Or if not, you can discuss if the patient should return to the cath lab to do an OCT during the admission to try to understand what can be going on, okay? And then all the possible diagnoses. Oh, that was too big. But again, this is the second part of the workflow, that is in patients who have an OCT. If it's completely negative, consider coronary physiology and look for spasm. If you see intimal bumping, again, as I showed you before, always think about spasm. If you have a plaque erosion or nodule, you have a diagnosis already. Intimal tear, you will have SCAD or coronary embolism. And then, now that we have the diagnosis of patients, this is the last slide, we can discuss of tailored therapies for these patients. So if patients have SCAD, at least they should be on aspirin and beta blockers. The use of the APT is not clear, but sometimes a short period of the APT of 2 to 4 weeks can be helpful. If they have an embolism, the patient should be anticoagulated and discuss if there's what is the source of the embolism. If they have vasospasm, calcium channel blockers or nitrates. If they have plaque rupture, DAPT, statins, and maybe beta blockers. In the case of plaque rupture, putting stents in a non-occlusive vessel has shown no major benefits. And there's a trial called the erosion trial that showed that these patients can be safely treated with DAPT without putting stents. And maybe in the future, they will require revascularization of these plaques that may progress in time, but usually they don't have more acute events. If patients have an unknown cause, they should be sent home with ACE inhibitors, statins, and maybe beta blockers. But there's also a lot of discussion if a patient has normal coronary arteries with OCT and normal MRI, if the patient actually has a MINOCA or not. And in the case of coronary microvascular dysfunction, depending on the phenotype, we can go with calcium channel blockers or managing the angina mostly, or patients who have abnormal vasodilation, they can benefit from ACE inhibitors and statins, okay? And most patients should try to be referred for rehabilitation and cardiovascular risk factor management, and hopefully psychosocial support. So as conclusions, MINOCA is a working diagnosis that encompasses multiple different etiologies. Using a stage approach and advanced imaging and functional techniques, a high number of patients we will be able to achieve the final diagnosis, and the medical therapy should be adjusted to this final diagnosis to improve outcomes and avoid side effects of medication. Okay. And to finish, every time I see Canada in the fall, I remember this beautiful song of Marillion that talks about how the leaves change from red to brown. Okay,
Perfect.
thank you very much.
Well, thank you very much for that fantastic talk. I learned a great deal. So I'll open up to the group for questions. You can either raise your hand or put in the chat, and I'll let people go. And while people are thinking, I'll start off with the first one. For cardiac MRI, my assumption is there are wait times in Hamilton. So for us, which subset of MINOCA patients do you think we should be trying to get the MRI more timely? It's probably not possible for us to get all MINOCA patients MR'd within the 14-day recommendation.
Yeah, I completely agree with that. So these are the Canadian guidelines, and I agree with them, but we have to take into account that MRI the MRI availability is limited. So for me, as a cardiologist, I think that the most important patients can be these young patients where we suspect myocarditis, because again, I think it makes a big difference in how we manage them in the future, especially in these recommendations of no exercise. So they are young people who are going to try to go back and do whatever they were doing before, and the risk of a sudden death because of the myocarditis is not low in the next couple of weeks or months. So these kind of patients, I think, are the ones we should push more to have an MRI, or at least in the follow-up period. But for example, the Takotsubo patients, I think they are not that important because the echo is quite diagnostic. And also that's why it's very good to see them together, because sometimes we can discuss about going back to the cath lab and take images, and we'll make a lot of diagnosis of those. But the young patients with suspicious of myocarditis, I think they are the ones that should have priority for this.
Perfect, thank you. And then kind of looking at the guidelines you brought up, within Hamilton, are you seeing kind of uptake in implementing those on a broad level, or do you find we're still kind of at the practitioner dependent? Is this just still an emerging kind of field that more education and awareness is needed?
So yes, I think this field is emerging. We still sometimes send these patients home with a normal angiogram with not a clear diagnosis, but it's improving. There's a lot of consciousness about this, and also especially the microvascular circulation lab has significantly grown. So if we suspect patients with microvascular dysfunction, they can be tested not emergent, but usually they can be planned, and in the short term they can be tested for that. So I think all the support is growing. The use of intracoronary imaging is also growing significantly. So I think we're in a good spot right now, but there's a lot of room for improvement too.
Thank you. I'll just check to see if any chat or any questions from the group. And then in Hamilton, is there at one point we had like a women's health cardiac clinic for a year, but I don't know if that's still going on, or a MINOCA clinic or something like that present or not?
A MINOCA clinic, yes, it's being set up, but there's not I think we have to talk about the way to refer those patients, but there's not a formal MINOCA clinic. There's a better, a more formal clinic for microvascular dysfunction mostly.
All right. Any other questions from the group? You can raise your hand or put it in the chat. All right. Everyone is good. Perfect. Okay, well, thank you very much, Dr. Winter, for that excellent talk. That was a great deal. I will definitely look up the guidelines that you referenced. As you know, we definitely see this a lot in general internal medicine. And, we usually just say nothing going on, discharge home, follow up with family doctor. So definitely, I think, opportunity for us to modify our practice. So thank you for highlighting this topic. And I'm sure there'll be more conversations moving forward on this. So thank you very much.
Thank you. Have a good day. Thank you very much for inviting me.